Hello, level 3 groups. Today's itis of the day is endocarditis. We are Chris, Lindsay, Jacqueline, Omed, and Stephanie. The pathophysiology for endocarditis is when blood flows through the heart and allows pathogens to infect previously damaged valves or endothelial surfaces of the heart, which is the innermost lining of the heart. The responsible pathogens usually are Staphylococcus aureus, Streptococcus viridans, fungi, and viruses. The inflammatory response caused by endocarditis is usually fever, clubbing of the fingers, chest pain during breathing, swelling in the feet, legs, and abdomen, some back pain, headache.
There are subjective and objective clinical manifestations for endocarditis. The subjective include chills, weakness, malaise, fatigue, pain, which include chest, spleen, local, abdominal, as well as flank. There's also abdominal discomfort and headache. For objective, we have fever, anorexia, arthralgias, myalgias, weight loss, clubbing of fingers, splinter hemorrhages, petechiae, Osler's nodes, J-Ways, lesions, Roth spots, systolic murmur, ischemia, gangrene, hematuria, renal failure, pulmonary emboli, neurologic damage, hemoptysis, respiratory distress, trapeze muscle, dyspnea, and pericardial friction rub.
An Osler node. An Osler node is a slightly raised, tender lump, often pale center. Pain often precedes these. Development is usually within 24 hours. They are typically found on fingers and toes, and they accompany endocarditis, usually a subacute situation. We just got to keep an eye on these, make sure they don't get infected when they do appear. Uh, they can last for hours up to several days, so it's just something to be wary of. The Janeway lesion is a micro abscess caused by a septic emboli. These will heal spontaneously with the treatment for the endocarditis. We just want to keep an eye on these. If they're not going away, treatment might indicate that it's being unsuccessful. But this is what a Janeway lesion does look like. It's a little nodule underneath the skin where bacteria is deposited.
Diagnostic tests that are used to diagnose endocarditis start off with a full health history, assessing if the patients have had any recent procedures done in the past 3 to 6 months, or if they have any history of heart disease, heart catheterization, heart surgery, intravascular device placement, dialysis, or infections. 3 blood cultures need to be drawn over a period of 1 hour from 3 separate sites. Culture-negative endocarditis is associated with antibiotic usage within the previous 2 weeks or results from a pathogen not being easily detected that is slow-growing. Because of this reason, cultures that are negative should be kept for 3 weeks if the clinical diagnosis remains as endocarditis because of the possibility of those slow-growing organisms. Major criteria that also include diagnosing endocarditis include 2 positive blood cultures that are assessed over 12 hours apart, non-valvular regurgitation, or vegetation that is noted in an echocardiography. A chest x-ray is done to detect cardiomegaly, which is enlargement of the heart, and an ECG may show first or second degree AV block.
These are the common medications for endocarditis. So IV antibiotics are primarily used. Some examples of those are penicillin, ceftriaxone, ampicillin, gentamicin, and vancomycin. And the use of antibiotics really depends on what comes back with the result of the blood culture and the sensitivity of the antibiotic. So it really depends on what comes back from lab, and that will show the type of bacteria that's present, whether it's a gram-positive or gram-negative, and what type of antibiotic will be effective in killing that type of bacteria. These are the treatments for endocarditis. So the first source of treatment is prophylactic treatment. Antibiotic prophylaxis is used. There's drug therapies such as IV antibiotics, and also medications such as aspirin or Tylenol can be used for the fever that can sometimes accompany endocarditis. And IV fluid is also given to help prevent dehydration. There's a surgical intervention such as valve replacements, and that's also used in conjunction with antibiotics, as with fungal endocarditis and PVE, they respond slowly and actually poorly to antibiotic therapy alone. So the early valve replacement is needed, and prolonged antibiotic use follows that, and that's usually 6 or more weeks after the valve replacement surgery. Patients are usually hospitalized. They're given the IV antibiotic therapy, and that's, as mentioned before, based on the blood cultures, and the effectiveness of the therapy is associated with the result of the culture. Sometimes the antibiotics will have to be changed if they're not as effective for that type of bacteria that's present.
There are several nursing diagnoses that are applicable to endocarditis, but 4 that are of primary concern. Number 1 is activity intolerance related to reduced cardiac reserve and prescribed bed rest. Number 2 is decreased cardiac output related to inflammation of heart lining, change in structure of valve leaflets, and increased myocardial workload. Number 3 is risk for imbalanced nutrition, less than body requirements related to the hypermetabolic state associated with fever. And number 4 is risk for ineffective peripheral tissue perfusion related to possible emboli presence in the peripheral circulation. Arthralgia, emboli, and progressive damage to the heart valve supporting the vegetations are common complications associated with endocarditis. All 3 conditions can be prevented from either initiating or progressing through the early administration of prophylactic antibiotics. Arthralgia, or joint pain, is a common occurrence with endocarditis and occurs from the systemic infiltration of the organism causing the infection. Identification of arthralgia includes observing the patient for joint tenderness, a decreased range of motion, and muscle tenderness. Additionally, the patient can be examined for Osler's nodes, splinter hemorrhages, and petechia. Emboli may result from the loss of fragile vegetation fragments into the circulation and is another common occurrence with endocarditis. Left-sided heart vegetations may impact organs such as the brain, spleen, and kidneys. Identification of these complications include both objective and subjective assessments such as observation for sharp left upper quadrant pain, abdominal rigidity, flank pain, hematuria, decreased GFR, aphasia, changes in vision, and altered mental status. Left-sided heart vegetations may also lead to emboli lodging into the small peripheral blood vessels of the extremities, interfering with peripheral perfusion. This can be identified by decreased peripheral pulses, pale or cool extremities, ischemia, and gangrene. Right-sided vegetations may circulate to the lungs, leading to pulmonary emboli. Identification of pulmonary emboli include observation for chest pain, dyspnea, hemoptysis, and shortness of breath. Local spread of the organism causing the vegetations may lead to damage of heart valves and their supporting structures. Common disorders associated with heart valve damage are dysrhythmias and abnormal valve function. Eventual invasion of the myocardium may lead to heart failure and heart block. Identification of progressing damage to the heart valves includes the use of continuous cardiac monitoring and sometimes heart catheterization.
We would like to thank our references for aiding us in making this presentation. Ackley, Ladwig, and Makic for their awesome work in nursing diagnosis. The Mayo Clinic for always having easy to find lists of signs and symptoms. DermNet New Zealand.org for providing us with some pictures. Circulation Journal also for providing us with pictures as well. And then Lewis, Heitkemper, Bouchard, and Harding for their knowledge in med surg.